And now, it's Boomer Life, lifestyle discussion designed to make your life more engaging, meaningful, and complete. Celebrating the baby boomer generation, this is Boomer Life on CIL 650.
Good morning and welcome to Boomer Life here on CIL 650. I'm Sterling Fox, and on the program today we are going to talk about your health with the two members of the professional team at Falls Creek. We have a guest in studio and a guest on the phone. Our guest on the phone is neurosurgeon Dr. Navraj Heran. Dr. Heran, good morning.
Good morning.
It's Dr. Heran. I apologize for mispronouncing your name. A very inauspicious beginning to the program. Doc, thanks so much for being with us.
I'm glad you corrected yourself because I would have corrected you otherwise.
I had no doubt about that part at all. In studio with me is physiatrist Dr. Stephen Helper. Good morning.
Good morning. You nailed it.
Well, thanks very much. That was a challenging occupation you have, Dr. Helper. Dr. Heran, let me start with you because I'm reading my notes for the show today. You are described as a neurosurgeon, and yet as I examine the details of the work you do at Falls Creek Medical Center, Doctor, it appears that you do a lot of work on backs. So can you help connect the dots between neurosurgeon and back work that you do so much of?
Sure. So neurosurgery is a surgical specialty that involves management of the neurological system as well as the spinal system. And spine refers to the spinal cord, nerves emanating from the spine, and the bony and structural elements of the spine.
Right.
So it's not just brain surgery, as a lot of people think neurosurgery involves.
And that's, I must say, I'm one of those people.
Yeah, most people think that. It does occupy about probably 50 to 60% of my time doing brain surgery.
Okay.
But the rest of the stuff that we do is typically involving the spine and sometimes the peripheral nerve, which is actually quite a bit less common.
Okay. And is there is the reason a neurosurgeon does that sort of spine work because the brain is so connected, if you will? It's so much of what happens in the spine ends up in the brain?
Exactly. I mean, and whatever goes through the brain in terms of motor function, sensory function, or reception, all is, at least for the body's perspective, is integrated through the spine. So the connections are obviously quite intricate and well understood by neurosurgeons.
Interesting. Now, of course, for those of us in British Columbia who are aware of spinal cord injuries, one of the first places that we all sort of think of automatically, Dr. Heran, is the G.F. Strong Rehabilitation Center. Is that, do you do work, do the patients who receive your surgical attention end up in rehabilitation at G.F. Strong?
No, that never happens.
Interesting.
As a spine surgeon who's operating on elective patients, my job is to make everybody perfect, so nobody needs rehabilitation.
Well, it's certainly you approach your challenge with bells on, by the sounds of it.
No, the truth of the matter is we do see patients when I'm on call. Particularly when I'm on call or seeing patients that have been transferred into the office for consultation with respect to either traumatic injuries or spinal cord tumors, for example. Many of those patients will need rehabilitation.
Right.
My main hospital, at least in the public system, is Royal Columbian Hospital.
Okay.
And rehabilitation needs for those patients, many of them are met locally, for example, at Eagle Ridge Hospital, Surrey Hospital, or Abbotsford. Some patients do require the expertise of GF Strong, particularly a lot of the younger patients or those who have marked immobility as a result of lower extremity weakness, for example, training on a wheelchair, bladder management, swimming programs, which aren't available at other places.
Right, okay.
To the same extent that they are at GF Strong. In Vancouver, though, the neurosurgeons and spinal surgeons deal pretty much exclusively with GF Strong.
Interesting. Now, G.F. Strong is also on the resume of our other medical guest. Dr. Stephen Helper is a physiatrist who has spent, in the past, some time at G.F. Strong, didn't you?
Absolutely. I spent my first year there.
After medical school?
After medical school, I spent a year on the spinal cord unit, really seeing Dr. Heran's patients.
Just a little bit of a shot there, friends.
Yeah. No, so, yeah, my job was to help with the rehab of patients who needed extended care in order to get their life up and running after a spinal cord injury, whether they be more of a mild injury or something devastating. That was my job as more of a medical physician.
Okay. But now, that's some time ago. You've been at the Falls Creek Medical Center for just a little over 7 years as a physiatrist. Would you please tell us, Dr. Helper, what on earth a physiatrist is and what sort of work you do?
Yeah, nobody knows what a physiatrist is.
That's for sure.
In fact, I think it took me the first year of school to figure out what that term meant. The real term for physiatrist is physical medicine and rehabilitation, but nobody likes to say that, so they say physiatrist, which is a nickname, or they say rehab doc, which is just another nickname.
Okay.
It's a 5-year specialty in medicine, and our other nickname is the internal medicine of orthopedics. So we're really medical doctors who deal a lot with orthopedic issues. And those orthopedic issues are really, if you want to just get rid of the medical terms, it's pain and injury.
Right.
So injury all the way up to, like we were just joking about gently, spinal cord injury.
Mm-hmm.
But it could be the walking wounded. It could be sports medicine. It could be back pain. It could be traumatic brain injuries, amputations, even strokes will deal with people with their function and their discomfort.
Right.
So my focus after I finished 5 years of physiatry was to do a year of spine pain medicine, which really isn't, not to confuse anyone, it's not spinal cord injury.
Okay.
Spinal cord injury is part of the general training of a physiatrist. But my true interest, the one that you are alluding to, my 7 years at Falls Creek, is spine pain. And that's pain from the muscles, the joints, or the peripheral nerves of the spine.
Right.
So the most common thing that you would think of that I would treat would be someone who has sciatica. Everyone uses the term sciatica. Sciatica is
sort of a generic back pain term, isn't it?
Yeah, I got back pain. It's shooting down my leg. Who do I see?
Right.
So they're going to want to see Dr. Heron if they think they need surgery, and they're going to want to see me if they don't think they need surgery. So that's the common herniated disc pinching a nerve,
right,
causing pain shooting into your leg. And that's more of what I do each day at Falls Creek.
Well, let me just follow up on that because gentlemen, this program is Boomer Life. So let me ask first Dr. Helper in studio and then to you, Dr. Heron, as well. As we age, is diminished back capability a part of growing old? In other words, as you grow older, are you likely to experience more frequent episodes of some kind of back pain, something else to grumble about? Dr. Helper, why don't you have a go at it first?
Yeah, I will. I didn't know if Dr. Heron was going to jump in there. I mean, I think I'm going to see a lot more of the mild to moderate end of pain.
Okay.
Whereas Dr. Heron's going to see more of the moderate to severe pain.
Sure.
As you know, assuming that the patients are directed smoothly, that's really going to be the trend. So yeah, I think that there is a dominance to my practice of those over 50 years of age.
Okay.
But it's still quite common to have severe back pain conditions when you're younger.
Mm-hmm.
But as you age, there's certain conditions that are just more and more common as we age. And we can talk about it. I don't know if Dr. Heron wants to comment on that, but there are certain conditions that just become more and more prevalent as we age. And the more fit we try to stay post 50, the more those problems act up. If you're lazy, sometimes these problems leave you alone. But if you try to maintain the athletic participation and the activity of your youth,
right,
as you start to get into the second half of life, these things tend to creep up and say hello in the morning.
Dr. Heron, would you agree that there's a certain sort of, I suppose, diminishment of capabilities as one gets past the magic age of 50?
I agree with him. I think it's a commonly understood aspect of back pain that as you get older, the likelihood of you developing problems with your back escalate.
Right.
Now, not the thing is, back pain is very common, but not everybody gets it in a persisting fashion. So most people in the population will have back pain at some point in time. That likelihood increases as you get older, but most people won't be incapacitated by it. So the ones we typically see are the aging people who are becoming increasingly incapacitated by it, whether it's from facet arthropathy or from spinal stenosis. The younger patients tend to have disc herniations, which usually resolve and then don't necessarily reflect upon them in the future of their life.
Right.
So they're very different groups of people that we see. Now, one of the other things that is commonly, at least not understood or accepted by many people, is as you get older, if you just have mechanical back pain, a lot of patients will outgrow it. So as their spine stiffens up as years pass by, they can eventually reach a point where their back feels better than it did when they were in their 30s and 40s by the time they're in their 60s and 70s.
Interesting. But I suppose at the same time, and probably in the same breath, we're more susceptible to injury, back injuries as we get older as well, especially if we're careless.
Correct. I mean, the process of disc degeneration means that the disc breaks down because it doesn't have vascular supply after adolescence. And so the disc weakens as time goes on. And as it weakens, that propensity for further injury in the future, whether it's with trivial activities or with major trauma, does increase.
Right. You reach down to pull up, pick up a heavy package, and you throw your back out and be uncomfortable for weeks because of one silly episode you forgot to lift with your legs, and you tried to do it with your back, and boom, you're out of commission for weeks.
Correct.
Yeah, I think we go through a real transition with our back. So if you think of the structures of the back, it's not like we're giving an anatomy lesson right now.
But I'd appreciate it a little bit. For example, Dr. Herron talked about a herniated disc, Dr. Helper. What on earth is a herniated disc?
Okay, I'm gonna take that question and I'm gonna twist it a bit. Okay. Okay. So we were just sort of talking about, what happens as we get older.
Yeah.
Okay. And not only is it more common for us to have some sort of back problem as we get older, but certain parts of the back tend to hurt more when we get older, and certain parts hurt more when we're younger.
Okay.
So if you think of being a 35-year-old laborer, and you bend down and you lift something heavy, and you go, oh, my back. Mm-hmm. Okay. There's probably about a 90%, and let's say that pain doesn't go away, okay? Because some of us might just.
There's always a twinge.
Yeah, a twinge.
Sure.
Okay. Let's say it's more than a twinge.
All right.
Okay. You're out of work. You're in trouble. You're in a lot of pain. You got primarily back pain. Let's forget about the leg for a second. Back pain at the bottom of your back. The likelihood is that you have done some sort of damage to the disc. Okay. Now the disc is like a hockey puck between the bones.
Okay.
Okay. It's like a bouncy hockey puck, or like a hockey puck with a jelly center. So when I talk to my patients, a hockey puck with a jelly center or a really strong jam buster donut, right? So it's like it's a bouncy hockey puck that allows us to absorb shock.
Sure.
Allows it, and it has some movement, allows us to bend and twist.
Right.
So when you do something like bend, lift, and twist, you basically torque on that hockey puck and you injure the inside. Okay. So you create a tearing in the inside of that hockey puck.
Right.
And that tearing may or may not be painful. When you're one of those unlucky guys where it becomes painful, you have disc pain. You have pain from inside the hockey puck.
Right.
And that's that back pain that we get in our younger age or young to middle age that can be quite debilitating. And when Dr. Herron was saying that the spine stiffens, it stabilizes over time.
Right.
That sort of hockey puck pain becomes less common. So when we're in our 50s and 60s, we have back pain, a lot of the time we're getting out of hockey puck pain and we're getting into joint pain. And there's two little joints on the other side, either side of the hockey puck, that can get arthritic and worn and torn over time, and they can become painful.
Right.
So that's just sort of talking about the way the spine sort of stabilizes over time, and as we get older, it can just change what's hurting us the most.
You were saying earlier, Dr. Helper, that you are more likely to see patients with mild to moderate back pain, and Dr. Herron is most likely to see patients with moderate to extreme back pain. Dr. Herron, if someone comes to you with that extreme back pain model that Dr. Helper just described with the hockey puck that's been damaged, there's damage done to the soft matter in the disc, is that an automatic surgery red flag for you, or are there other remedies?
No, most people have the misperception that surgeons, all they want to do is just operate. And so if you're being referred to a surgeon or you've seen a surgeon, that the fellow or the woman's going to basically operate on you because that's what they do.
Exactly.
I would say about 90-95% of the patients that I see in the office that have back pain or a variant of back pain, either with leg pain or discogenic pain or facet-mediated pain, majority of those patients do get better on their own in the short term. It doesn't mean that they're not going to necessarily have recurrent episodes in the future.
Right.
So we do still give them the protracted benefit of time in order to allow them to alleviate their symptoms,
right,
get better, get functional. Now, there's some patients who are going to have obvious red flags right away. An example of that would be a foot drop, an individual who has sciatica, pain radiating down their leg. They may not even have that much back pain. It may just be in the buttock and down their leg.
Right.
And with that, they have difficulty or absence of ability to pull their foot back. So when they walk, they trip on their foot. And if that happens acutely, that's truly considered a medical emergency because the results without operating are poorer than with operating. Similarly, with the Cauda equina syndrome, which is a constellation of neurological problems associated with a disc that squishes the spinal nerves, typically between L1 and the sacrum, and it specifically knocks out your bowel and bladder function, which is, again, a major medical emergency.
Absolutely, yeah.
And in that setting, those patients need to have surgery, and the best evidence says if you have them fixed within 24 hours, that their long-term outcomes are far better than not doing anything.
And there's the beauty of the Falls Creek Healthcare Center, isn't it, Doctor? Because you can get that, you can do that turnaround. If someone comes to you in that kind of excruciating, extreme difficulty, and they need attention best dealt with in the next 24 hours, thank you very much, they can get it done in 24 hours at the Falls Creek Healthcare Center, correct?
That's actually incorrect.
Oh.
So those are considered medical emergencies, and that's where our healthcare system is best at serving.
Oh, okay.
When a person does require an intervention, for example, if you have a heart attack, you need to go to the hospital, get assessed by the emergency doctor, get assessed by the cardiologist, get TPA, and get your catheterization done and get on with your life.
Right.
And same with the Cauda equina syndrome or acute foot drop. Those are hospital-based problems. Things that in elective centers, for example, patients who are waiting many, many months for surgery are the same things that they benefit from by having expedited on their own. A typical example would be a WorkSafe patient or a patient who's under the RCMP's healthcare program, and they end up with a disc herniation. They have sciatica radiating down the leg, no true weakness, but they can't function. They can't work. They can't pick up their 2-year-old daughter or son. Those are the patients who often seek the private route to get on with their lives, get their surgeries done, and get fixed.
Right, just accelerate the whole process.
Accelerate the process.
Right.
And for a lot of those patients, it can mean thousands and thousands of dollars saved if they can get back to work sooner, as opposed to being on disability or being off work, self-employed for a year or two before they can actually get their interventions done.
Exactly.
So places like Falls Creek are best served for those, but when you have a true medical emergency...
Off you go to the ER, right?
You go to the hospital.
All right. We need to take a quick break here. Our guests from the Falls Creek Healthcare Center, neurosurgeon Dr. Navraj Heron and physiatrist Dr. Stephen Helper. I'm Sterling Fox. You're listening to Boomer Life on CIL 650. Lots more still ahead. Stay with us.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIL 650.